I'm Rob Martin, and I'm one of the teaching fellows and specialist registrars in geriatric medicine in Cardiff and Vale. I'm going to talk a little bit today about comprehensive geriatric assessment. So I start with a question. What is geriatric medicine? What is it that makes us special? What is that makes us different from cardiologists, from respiratory physicians, from gastroenterologists? And I hope by the end of a brief discussion you'll be able to have an answer for that. I'm going to introduce to you this concept of comprehensive geriatric assessment, CGA, and the different areas that it involves. So you can see here from the diagram, to begin with, there's the physical health. We're all familiar with this, of course. This is what we presume that you'll be doing as part of medicine, investigating people's problems, whether it be stroke, infection, whether it's problems with arthritis, whether it's problems with your chest. These all fall under the remit of sort of physical health. Mental health is another area that impacts on so many of our patients, whether we're talking about a delirium, or whether we're talking about dementia, or whether we're talking about depression, or another underlying diagnosis, such as schizophrenia or bipolar disorder. Don't forget, elderly patients are not immune to these conditions. Maybe it's something that they've been dealing with for many years. Maybe it's something that they actually haven't ever been diagnosed with, and it's only now coming to the fore. You have to think very carefully about the social circumstances of our patients, because so many of their problems are impacted on by the fact that they are in a different environment to some of us. So they may need care, they may already have it. It might be that their family are able to deal with their problems, it may be that they're not able to help them. They might have carers, they might not. And actually, so many things that we see might well be easily dealt with if someone's social circumstances are assessed and dealt with. The same goes for someone's environment. So it might be that they are in somewhere that might not be the most suitable for them. So if they're in a large house, for example, and their bathroom is upstairs, this is going to exacerbate all their problems with continence, maybe an awful lot more than if it's on one level and they only have to walk down the corridor to go to the bathroom. And then we've also got this area of functional capacity, which is thinking about what our patients are not able to do, and of course what they are able to do. Lots of illnesses that affect the elderly, of course, impact on your ability to do things. If you're left with a severe hemiparesis after a stroke, there are certain things that maybe you aren't going to be able to do because of your mobility. And these are things that we need to think about. Lots of problems with our patients can be looked at in this way, comprehensively, can be looked at quite differently. So you can see how someone coming in with multiple falls, that classic way of looking at their problem with a history of presenting complaint, their past medical history, their social history, their medication, actually might not be the most fitting way to assess them. But actually looking at it in all of these different areas might be a better way and actually offer a more likelihood of actually coming up with a plan to manage their problem. Now, this is not the remit of only a geriatrician, and in fact we work as a large MDT to do this. So we need the help of our therapists, of our nursing colleagues, etc. And we'll talk about that shortly. But we need to think when comprehensive geriatric assessment is useful. And actually it's useful in a large number of circumstances. So when somebody is admitted acutely and they're elderly, then they should have a comprehensive assessment at that point. It might be that their admission isn't really because of a medical problem. Maybe it is a social or environmental issue that actually doesn't require an awful lot of changing from a doctor, but a visit from an occupational therapist might well solve the issue. For those people who are being admitted frequently with problems, again, it might be that a physical health problem isn't necessarily the underlying problem, and it might be one of those other domains that we've spoken about. But also, there's that interplay between having a complex physical illness and the social situation that you find yourself in. And then in clinics like the Elderly Care Assessment Service, we can actually try an avoid admission. So where those people have been recognised as having problems that might well lead to the necessity of a hospital admission, for example, multiple falls, worsening confusion, then actually we can try and step in early for a multidisciplinary assessment, assess them in all of these different areas, and then put a management plan in place that means they may never have to come to the hospital at all. For those people who are about to be undergo rehabilitation, so for those people who maybe have come in with a severe pneumonia, they've come in with a life-threatening medical illness that's left them to be in bed for a number of days, become incredibly unwell, you need to be thinking where you're aiming for from their rehabilitation point of view. And actually comprehensive assessment then is very useful. So we can have a look at where they were before they came in. We can see where we are anticipating them going. You look at their environment, their social situation, and what they're now able to do, their functional capacity, to be able to set realistic goals for their rehabilitation. Without these, people are going to potentially have unrealistic expectations of the recovery they are anticipated to make from their problem. There's also this growing area now of perioperative medicine. The one that you may well have heard of is orthogeriatrics. So this is where a geriatrician is involved in the medical care of the elderly people on an orthopaedic unit, and there's good evidence that this actually improves the outcome for these people. So the orthopaedic surgeons are supported in dealing with patients who are medically very complicated. Patients, of course, that they haven't been trained to look after, but who we, as geriatricians, deal with every day. As I've said, this is not something that can be done by the geriatrician alone. And in fact, there is evidence to say that all of these components of comprehensive geriatric assessment, if done by a single person and a single specialty, actually doesn't work. So yes, the geriatrician might well be at the centre of the MDT. Of course, it is to them that the patient has been referred at some point, but working alongside them are a number of different medical professionals. So of course, we have the nursing staff whose expertise lie in a completely different sphere to our own. We have physiotherapists, experts in being able to mobilise a patient, issue them with appropriate walking aids. Occupational therapists, people who will be able to go in, visit the patient at home, and actually have a look at any changes that can be made at their home address to be able to make things easier for them. That might well be as simple as installation of handrails to be able to help them get up the stairs. It may be more complicated, such as the installation of a stair lift. Or it could be suggesting that actually this person's care needs are so great from that point of view that they need to think about going into some kind of residential environment, somewhere that's specially designed to be able to deal with this sort of issue. We've also got social workers, dietitians, we've got various other things that people who will step in and help us deal with the complex problems that we find on a daily basis. In certain environments, ECAS being one of them, we've actually got very rapid access to social workers to be able to arrange for care at home for people where that person looks like they might well be failing, where they're needing help with washing, dressing, etc. And this is something that's going to end them to come to hospital. We can step in and within 24, 48 hours put an emergency care package in place that's going to mean that person can stay at their home address. So, I'd like to have a look at this referral, and I'll read it to you. Would you kindly see Mr. Jones? He lives alone and has started to fall frequently. I am concerned he will need admission soon without any intervention. He's got a past medical history of hypertension, benign prostate hypertrophy, atrial fibrillation, ischemic heart disease, and has suffered with angina since 1999. His medications are amlodipine 10 mg, aspirin 75, ramipril 7.5, tamsulosin 400 micrograms, bisoprolol 5 mg, simvastatin 40 mg, and frusemide 40 mg. Take a pause and have a think about how you might well be able to assess this patient and what possible causes there are for his falls, thinking about those different areas: the physical health, the mental health, the social situation, the functional capacity, and his environment. So although initially this sounds like a very medical history, you can see he's having falls and he is on lots of antihypertensives, tamsulosin, all of which can potentially lead his blood pressure to drop. There'll be lots of other reasons why this man might be falling, and it might take a few thoughts outside of the box to think about them all. But if you split them into those different areas, so physical health, he may be having problems with his blood pressure. I've mentioned the fact he's having angina. Is he suddenly having gripping attacks of angina and then collapsing to the ground because he can't cope with the pain? He's on lots of medication and maybe that's exacerbating his problems with his blood pressure. Talking about mental health then, there's nothing in the history to suggest there may be a problem, but of course this might be an elderly gentleman living by himself. Maybe he's feeling very low in mood, and maybe that's leading to him just to not look after himself as well as he maybe should do. We don't know, with regards to his functional capacity, what his mobility was like before. How much deterioration has there been? Social situation wise, well, he maybe have been issued a stick or a walking frame previously, and now he's just not using it. A lot of people will see that as a sign that they are an old person and don't want to be involved with that. They don't want to be looked at as if that they are a frail elderly person. Maybe he doesn't have appropriate support at home. Maybe all we need to do is step in and make a change. Maybe he's falling every time he goes to put his shoes and socks on because he's got problems that mean he can't bend down. And actually, all we need to do is put some care in to help him dress in the morning and evening, and we can severely reduce his risk of falls. Maybe his home environment isn't necessarily the most suitable place for him anymore in the way it is at the moment. So maybe he's having to climb the stairs frequently. The bathroom might be upstairs, and we saw he's on diuretics. Maybe he's having to run to the toilet frequently, a physical health problem. And then, because the stairs are quite steep, because he doesn't have any rails, he's then falling on the stairs. Obviously, there are lots and lots of other reasons why he may well be falling, but you can see that these can be classified into these different areas, and then there's complex interplay between all the different areas. So this case is slightly different. In this case, an elderly man is living at home alone. His daughter visits to find that he's been losing weight now over a number of months. She takes him to the GP, who suggests a referral to the local geriatrician in an elderly care assessment service. The daughter is so concerned about him that she suggests that he might well need placement. He's got no real medical problems other than a fractured tibia back in 1993 and doesn't really bother the doctor very much. This story is slightly different. He doesn't have an underlying medical problem, but still has ended up with the geriatrician. The story here is that his wife has recently passed away, and actually she was always the one who was responsible for making dinners, for doing the shopping. And without her, he's not really able to do it. Don't forget, people like this got married in a different era, when there were different expectations of male and female roles. Actually, we might be able to solve his problem, solve his weight loss, with some carers in place and maybe some Meals on Wheels or something, or a company going in to provide microwavable meals for him. That said, just because you think you've identified it, you need to think very carefully whether his weight loss is due to an underlying malignancy, and you should always be thinking about screening questions whenever you hear about unexpected weight loss. It's also, of course, not impossible that he has become depressed after the death of his wife, and actually some treatment with an antidepressant might be appropriate here. It also might be that he could benefit from seeing a psychologist to talk through his issues instead of medicating him. So, I asked the question I started again with: what is special about geriatric medicine? What makes us different from other specialties like cardiology or respiratory? The difference is that we are a person-centric specialty, and we may be the only medical specialty that is not looking at an organ system. Because of that, we get lots of problems coming to see us that actually might not be medical, but we deal with them all the same. So you've seen here a case that has underlying medical problems that require assessment and maybe changes to medication, and you've seen at the other end of the spectrum one that's very social, in that a man is losing weight because he's not able to cook for himself. Yet even so, these two cases have come to our attention by the very same service.